This video covers fluid resuscitation in burn patients, energy balance, and nutritional management following burn injury. The principle of fluid resuscitation is to maintain intravascular volume. This ensures sufficient circulation to perfuse vital organs and damaged peripheral tissues. Intravenous resuscitation is appropriate for children with burns over 10% total body surface area, or TBSA. For adults, the figure is 15% TBSA. Significant diuresis is rare in the first 24 hours due to stress hormones. Hyponatremia and water intoxication can be fatal. Fluid needs are calculated using standard formulas, and monitoring urine output is key. Formulas help calculate the approximate volume of fluid needed for resuscitation based on the patient's body weight and the percentage of body burned. Three main types of fluid are used: Ringer's lactate, human albumin solution or fresh frozen plasma, and hypertonic saline. The Parkland formula is one of the simplest and most widely used. The Parkland formula calculates 24-hour fluid replacement as total percentage TBSA multiplied by weight in kilograms multiplied by 4, which equals the volume in milliliters. Half is given in the first 8 hours, and the rest over the next 16 hours. Ringer's lactate is the most common crystalloid. Crystalloids are often as effective and less expensive than colloids. They are preferred because large protein molecules can leak from damaged capillaries after a burn injury. For children, maintenance fluid must also be given. The Holiday-Seeger formula is used, which includes dextrosaline based on weight increments. For example, a 25-kilogram child needs a total daily maintenance fluid requirement of 1,600 milliliters per day, calculated using the Holiday-Seeger formula. Hypertonic saline is effective for treating burn shock by producing hyperosmolarity and hypernatremia. Advantages include less tissue edema and fewer necessary escharotomies and intubations. Human albumin solution, or HES, is a commonly used colloid. Plasma proteins maintain plasma volume. Proteins should be given after the first 12 hours of the burn. The Muir and Barclay formula is a common colloid-based calculation. The Muir and Barclay formula uses 0.5 times the percentage body surface area burnt multiplied by weight to equal 1 portion. This portion is given in periods of 4, 4, 4, 6, 6, and 12 hours. Monitoring resuscitation relies on urine output, which should be between 0.5 and 1.0 milliliters per kilogram of body weight per hour. If output is low, increase the infusion rate. Do not over-resuscitate patients. Urine output exceeding 2 milliliters per kilogram per hour signals a need to decrease the infusion rate. Other monitoring tools include acid-base balance and hematocrit measurement, especially in larger burns. For children with burns over 10% TBSA and adults over 15% TBSA, consider intravenous fluid resuscitation. If oral fluids are used, salt must be added. Fluids are calculated by formula, and urine output must be monitored. Severe burn injury causes a hypermetabolic response, requiring high-calorie intake for healing. Predictive equations help estimate energy needs, but care must be taken to avoid overfeeding due to changes in management. All inpatients with deep burns are assessed by a dietitian. Nutritional goals include promoting healing, minimizing complications like infection, maintaining normal nutritional status, and minimizing metabolic disturbances. Key objectives are to provide nutrition enterally within 6 to 18 hours, maintain weight within 5 to 10% of pre-burn weight, prevent micronutrient deficiency, and minimize hyperglycemia and hypertriglyceridemia. Early enteral feeding within 6 to 18 hours post-burn is beneficial in adults and children. It improves nitrogen balance, reduces the hypermetabolic response, and lowers immunological complications and mortality compared to parenteral routes. Aggressive nutritional support is often required. Young children with severe burns frequently need nasogastric feeding to meet elevated energy requirements. Protein requirements are substantially increased, with 20% of calories from protein linked to improved outcomes. Increased requirements exist for nutrients associated with healing, such as vitamins A, C, E, some B vitamins, and zinc. Supplementation with fish oil and arginine may also be beneficial. The Carreri formula is often used to estimate daily caloric requirements in patients with major burns, using separate formulas for men and women based on weight, height, and age to calculate basal metabolic rate.